Good evening, all. After a very long time, we are going live today. Though the exam dates are getting postponed again and again, we are forced to balance between the final year subjects and the pre-final year university exams. So we are in a situation where we have to keep on revising our pre-final year subjects and also listen to the online classes conducted for final years. So here we Medusane bring you exclusive sessions for the revision of ENT, Ophthalm and Community Medicine in pre-final subjects. So we have today Dr. Major Vasanth sir, ENT surgeon from Armed Forces and Professor of ENT to discuss all the essay questions in the topic Larynx. This will be extremely useful for you guys for revision, and I request you all to listen carefully and side by side prepare and excel in your university exams. Thank you, sir, for joining us today's session.
Thank you, Raghu. Thank you for the introduction. So let's start with the essays in ENT. I'll start with the throat section, more of in the larynx part. So there are various types of essays. So before going into the essays, I would just going in and revising the chapters. I think it is better to go and analyze how to prepare and just know how to attempt the questions. Even if you, I know you will be writing very well in the exams. You would have prepared a lot. The theory is not that. Vast as medicine or surgery in ENT, but it's okay. In ENT, you can revise it very well within a week or 10 days. So before that, I will just give some tips and tricks and how to go with these exams and how to prepare these topics. Okay. So before the preparation starts with reading from the standard books. Read from the standard textbooks, which like Dingra, like Bansal, Mohan Bansal. Okay, start for reading the standard books. Because why? Because whenever you, because ENT here you are exposed to the clinicals for the first time. So in clinicals it is one-to-one talk with the external examiner or the internal examiner, whosoever is going to be there for the exam. So you have to talk one to one, and if they ask you from where you read this, then you have to give the reference from the standard books only. So I would request you to read only from the standard books. And some topics are really not given in what to say, in a great sense in from the standard books. For those topics, you can go to some reference books in ENT, and but remember, whichever topics you had studied in other books, you have to be well versed with it, and remember from which books you had read that. So read always from the standard books. uh, don't try any shortcuts or anything, because standard books in ENT are very very less, and KKR, Dingra, and Mohan Bansal, and Hazarika are some of the few books. So it's very easy to go through it and very easy to revise it also. So even if you read from the standard books, your revision becomes easier, because without revision it's very difficult. Revision is very very must. And while reading, whatever is it, if it is an anatomy or if it is physiology, or even if it is the disease part or any pathological condition, read as a concept. It's just the concept building. You have to understand it clinically, and you have to understand it theoretically also. You have to you imagine keeping a patient of that pathology in front of you, and then you are starting to read. Okay, so the clinical things are very very important. Give emphasis for the clinical things, so that when you are going and sitting in the clinical part, you will be very well what to say, very well equipped and very well knowledgeable in terms of answering. So it's in ENT you will be what to say, you will be for it was the first time you are going to attend the clinicals. So clinicals, in one-to-one discussion, it is very very important that how much concept you have built in it. So if it is like, for example, if it is a physiology of the ear or a physiology of voice production, you should know how to build the concepts. So you have to know whether how the physiology of the ear works and how the voice production is takes place, and then you should be very well versed with that, so that even if you remember the small amount of things and if you know the concept, the examiner from your answer, he gets a very great understanding that he will know that this guy has understood it, because the examiners are more most often or not the first timers. They would be seeing many more exams and they would have seen many students like you, so they will be knowing that okay, this guy has, if even if you fail to communicate it, they would know, they will predict that okay, this guy is unable to communicate but he knows the answers type. Okay. Okay. And whenever you are reading preparing for the exams in the study time or in the study leave, you have to practice the diagrams are very very important. Any anatomical questions and any whichever what to say, whichever answers demand a diagram, you have to draw it, because even if your diagrams are not that great, or even if it is very immature, or even if it is very simple, there is no, there should be no hesitation in giving your diagrams. Just practice the diagrams whenever you start preparing for the exams. Okay. And go through the previous papers, question papers in the last 5 to 10 years. That's very very must, because 70% of the questions are repeat. So you can very well know that once you go once you see the question papers, you can see many repeat questions from it. So we should not leave those questions, and you can it guides you in preparing. So this is how the pattern of question you are going to come. So go ahead with the previous question papers every time for what it's not only for ENT. I'm just speaking for the general preparation as a whole. Okay. Then comes the presentation. The presentation part is how you present your answer in the exam. So your handwriting should be really what to say, you have to work on it. And numbers, key the question numbers should be very 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 precise. If you are writing the second question as the first, then you have to write the second number, you mention the second number two, and write I would say you can write the question also in the black ink, so that you can write the answer below. That will guide the examiner whosoever is correcting it. Okay. And give proper spacing between one answer and the other answer. If you are going to start the next answer, next question, give a proper spacing, at least one or two line spacing, and then go ahead, because most of the time we never know that the second you had answered this question, because it is very well what to say, easier to just skip through your answers without seeing it. Okay. And subheadings are very very important. The moment they see, the examiner sees the subheadings, then he knows that this guy has prepared, this guy has know something about how to answer in the exam. Okay. And diagrams, as previously mentioned, you have to draw the diagrams. There is no escape from it. Even if you are very bad in drawing it, even if you are not good in drawing, no problem, you just attempt the drawing. Okay. And be precise in your answers. Don't uh, elaborate, or don't write unnecessary things which are not asked, because the examiners are nowadays very very clear about, and those who are coming for the correction, they are very clear. They just see whether you had written that key point. So you hit the bullseye. If they ask what is the etiology, you write what is the etiology. There is no need to write introduction part and the other things. So be precise. If you are precise enough, then you are very well, you can fetch good marks. Okay. They just see that highlighted things, that's all. If you had answered that part, then they just go for the next question, that's it. And the definitions, be very clear, and read the definitions clearly, so that you can reproduce it as good as possible. It is very difficult to reproduce the definition from the book, but at least you can have 90% of the reproduction from it. Okay. So enumerate if you have any either like causes of hoarseness of voice, or any causes of dysphagia or anything like that. If you have a question, you have a very big list of etiological causes which leads to these conditions. So you enumerate it so that it looks nice and proper. Don't haphazardly write here and there. You just enumerate it, list it out, so that the examiner has a very clear whatever whatever it see it, many after mostly a year of preparing for ENT, you know something about ENT. It's not like you doesn't know anything about ENT. You know something about ENT, and over a period of time, you passively learn many things from the clinical side, from the theoretical classes, and from discussion with your friends and with your lecturers and tutors. So such knowledge is there, but the problem is we don't what to say, connect with it. We don't connect with the questions. We just get carried away with the questions, and we start just going with the flow of the question. But just think about it. You know the answers. You really know the answers. It is just that you have to present it in a very nice manner so that it comes out in a very neat and effective way. Okay, so the whole question paper, and going through the various previous year question papers also, I think the questions which are asked in the exams will lie only in these three, four, or five categories. Okay, one will be the anatomy. It is a direct question from the anatomy. That's it. It might be anatomy of the larynx, anatomy of the vocal cords, muscles of the larynx, membranes of the larynx. Okay, so it might be a very direct question. It will be from the anatomy only. Okay, the next one is a disease or a condition. It might be like acute laryngitis, acute epiglottitis, or carcinoma of the larynx, or it can be a Plummer Vinson syndrome or a retropharyngeal abscess. So these are disease or conditions, or the pathological conditions which takes place, which comes there. Okay, so either it might be an anatomy, or it might be a disease or a condition, or sometimes you might be asked for a surgery or a procedure. The most common is the tonsillectomy. You might be asked for a tonsillectomy surgery. Okay, they just give the question as tonsillectomy indications, contraindications, complications. That's it. Or they may ask you how the procedure is, or what the types of tonsillectomies you know. So it might be a surgery. So just with the question paper, you can analyze it. How many questions from anatomy, how many questions of disease or condition, how many questions they had asked about surgery or the procedure, and sometimes test like the tuning fork test or fistula test, or something like a rhinomanometry. Okay, or something like stroboscopy. Those are tests. So they will just ask you about those tests. Okay, so, or it can be sometimes, if you are very, very unlucky, you may be asked about some drugs. So, like nasal steroid spray, or some cetirizine, antihistamines. So, there are some antifungal citroconus or something like that. Okay, but drugs usually doesn't have a much role in the question papers of undergraduates, but in postgraduates, yes, we do get at least one or two drugs in our question papers. Okay, or it can be an investigation like a CT scan or an MRI, a barium swallow, or something like that. So it might be, so any question can be categorized under these conditions, topics. It can be an anatomy, disease, surgery, test, drug, and investigation. Okay, so everything has a blueprint. So once you see, the question paper can be classified into these things: anatomy and disease, and test, investigation, and surgery, and other things, and each one has a blueprint. So if you know the blueprint, if you know it in your brain, mind, then you can easily reproduce it. So like for anatomy, what is the blueprint? In anatomy, the first one is, if it is a muscle, then you have to state from where is the origin, or where, which is the origin and which is the insertion. If it is a space, parapharyngeal space, retropharyngeal, something like that, so you have boundaries for those spaces. Okay, and divisions like a parotid gland is divided into the superficial part and the deep part, and even parapharyngeal space and the peristyloid and the poststyloid compartment, like there are divisions. Okay, in anatomy you have anatomical divisions of that anatomy. Okay, and if it is a space or if it is something else, or if it is some um, what to say, if it is an organ, then what are the contents in it. So you can just know what are the contents which is inside that, and what is the significance of that contents, and what is the significance of this anatomy, whichever they ask, if it is a muscle or if it is a gland or whatever it might be. So you can get to know what is the significance of that. And then comes the applied anatomy, and then comes the surface anatomy. And for every anatomical question, there is no other go, you have to draw a diagram to impress them. If you're good at it, you get the full marks. If you're bad at it, you get most of the marks actually. So this is how an anatomy, usually you very well know from the first year, you know how to attempt an anatomical question. So this is how it should be attempted. So it's very easy. And I left the blood supply, the nerve supply, and the extensions of those things, the relations of things. Okay, so any given anatomical structure can be very well explained with this blueprint. Okay, then comes the disease and the condition. Disease and the condition, very very easy. Once you think about some disease, when a question is about a disease, then give an introduction of it. Okay, what is the disease like? If it is like allergic rhinitis, or if it is a chronic rhinosinusitis, just give an introduction of what is the rhinosinusitis. It is just an inflammation of the nasal cavity and the paramucous membranes of the paranasal sinuses. That's it. The intro, give a brief introduction about it, and then go for incidents. Some diseases are very very common in females, some are very common in the males. The Plummer Vinson syndrome, or the Kelly syndrome is very 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 common only in the females. So some diseases are um, dominated by the male population, some are dominated by the female population. So you give the how much is the incidence, whether it is 1 in 1 lakh, or some disease usually have an incidence. If you know that, it is very good. If you don't know, no problem, at least try to mention whether it is sex oriented and in which age group it is going to affect it. Okay, so that is very important. So introduction comes the sex and the age group, and then comes the etiology, the causative factors. What are the causative factors of this disease? Whether it is infection, whether it is that this, you have various sort of etiological factors. And then comes the clinical features. In clinical features, you can give the signs, the symptoms. Okay, the signs and symptoms are the usual things which we see in the clinical features. Just imagine a patient presenting with that disease, and then you can very well give the what is it, you can very well you can very well give um, what are the signs and what are the symptoms of those disease. And in investigating part is what are the investigations you are going to do with it. So whether it is an imaging, whether there are some specific investigations which are going to be done for that disease. And then comes the treatment, how you are going to treat it, whether it is medical treatment or surgical treatment. Just briefly mention about it. And then comes if there is any rehabilitation part, like carcinoma of larynx do have a rehabilitation part. So after treatment comes the rehabilitation and how to prevent the recurrence. That's it. So any disease can be can be easily dealt up. You can just fit this one, these subheadings in any of the disease or any pathological condition, so that you can clearly have an idea, and you can write the answers in a very nice manner, so that it gives a very clear cut picture about what you are dealing with. So the examiner will also know that yes, uh, this will know that yes, we are good. The presentation is so good that this guy knows how to answer. Okay, and then surgery, the blueprint of the surgery. So any surgery, you just go and know for the history part. So what is the history of the procedure? What are the who did for who did it first, and what are the what modifications after that it went through, and then comes any surgery or any procedure, what are the indications. So what are the indications and what are the contraindications? Any indications, what are the indications, and then contraindications. Contraindications are can be absolute contraindication, that the surgery is absolutely contraindicated in those conditions. And then comes the relative contraindications, where it can be done under guidance or with risks. Okay, and then comes the procedure. The procedure, briefly mention about the procedure, how it is done. It can be the approach or the route, and if there are any variations with that procedure, like some procedures can be done even cold steel, some procedure can be done with a laser, some procedure can be done using a harmonic scalpel, some can be done with a compilation. So there are variations with this. The procedure can be done with that, can also be mentioned. And then comes as last the complications. So any surgery can be dealt in these subheadings, so it is very easy for you. So once you see that, okay, if you get a question like example tonsillectomy, you very well, you can take it into your mind that, okay, fine, I'm going to write it: indications, contraindications, procedure, variations, complications. I think you know this, because over a period of time you have accumulated the knowledge of tonsillectomy in the clinicals and from the theory and from what you have learned, so you can easily fit into these categories. So it's very easy that you can write down 2 pages for a tonsillectomy, isn't it? So it is very easy. So just have the blueprint for this. And for the test, if it is a test, then each test has a principle. If it is a fistula test, or if it is a tuning fork test, it is a principle that we are going to check the air conduction and the bone conduction, and we are going to compare it. That is the principle of the test. So if it is a fistula test, we are going to check the imbalance. So any pressure changes outside, if there is a fistula, it will going to travel to the vestibular compartment, and then it produces a vertigo. So we are going to check for that. So any test has a principle. And what is the aim is what you are going to see, what you are going to achieve. Then the procedure, how it is done, and then the inference, what are the how you are going to infer from it, and what are the results. So if it is negative, what is it is, if it is positive, what it is, if it is false negative, what it is. So there are so much the results. And then is there any modification to the test? Nowadays in modern medicine, we had modified some of the tests. So if there is any modifications, you can write it down there. So any test can be given with this subheadings. If it is a drug, it is very easy. You had already known that in pharmacology, you had seen it as an introduction, mode of action, indication, contraindication, side effects. That's it. If it is an investigation, it is more like a test only. So investigation is also comes under the same thing principle. And here, if for any investigation, you have to know whether it is indicated, what are the conditions where you are going to do that investigation, and how you are going to do that, the procedure, and what are the inference from it. And if there is any modification or variation, then you can go ahead. So coming to the larynx now. So going through the previous papers, I had seen many of the topics are repeated, and and one or two questions are very, 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 what to say, very standard. They keep on asking every 2 to 3 years. I don't know why, but I think they have to refresh their question bank. I think because it keeps on repeating. For example, the Stridor and tonsillitis, it keeps on repeating at least once in 2 to 3 years, in not only in Tamil Nadu papers, even in Karnataka, even in Kerala, it is the same. Okay, so I went through the question papers in the last 10 years, and I had compiled only the very few essays. Okay, because I just gave the blueprint. Just it's not like we are going to it's not like a typical class where I can explain you the whole topic, the all the essays, because it is very difficult. One essay actually used, during our post graduation days, um, the seminar topics of the postgraduates is given to the postgraduates. They have to take seminar every. We used to take seminar every week, and our topic was one of the essays. So we used to get one of the essay as the topic. So that after reading so much in that, so you will be able to write it very fluently. That's what it is. No, so we were given only the essays as topic. So you can imagine each topic itself is a topic on its own. So one essay can't be. I can't. What explain the whole lot of essays which has been in Larynx, but that's why I gave the blueprint of how to see, how to go about the questions, and how to go about in answering it easily. Okay, so since you know that, it will be very easy. I'll just give 2 3 examples of how to answer it. So after you see that, it is very easy. You can attempt it on your own and then check it, and then you can see that okay, this is how it is going to work it. Okay, so the first question, the most repeated topic is Stridor. I don't know why. The Stridor is very much repeated topic. But they usually ask about the causes of the Stridor, and what is its the Stridor in children, and the management of foreign body in the airway, and laryngomalacia. Sometimes they are laryngomalacia most of the time comes in short notes, but sometimes as a part of say it is there. So Stridor is nothing but you have I told now Stridor is a disease or a condition. Okay, so just go and mm, just what is it? Just get the blueprint now. What is the disease of a condition? Okay, now what is the definition of Stridor? Stridor is nothing but an abnormal high-pitched sound produced by the turbulent airflow through the obstructed airway at the level of the supraglottis, glottis, or subglottis, and this is the definition. Okay, you define it, then go. What are the types of stridor? Inspiratory stridor, expiratory stridor, and biphasic. Inspiratory, the obstruction is somewhere in the larynx. Expiratory, the somewhere in the trachea. Biphasic, when it is in the subglottis, it affects both the inspiration and expiration, hence it's biphasic. And what is the pathophysiology? Simple Bernoulli's principle. When air passes through a narrowed flexible uh, tube, it produces turbulence, and that produces the sound. Okay, so that's the Bernoulli's principle. And then comes the etiology. What is the etiology? There are so many etiologies, causes that has been listed out, but you can see it very easily. Just imagine this. The etiology can be classified into level of obstruction. If the stridor, where it is obstruction, okay, and then for how long it was there, duration, and then the age group. Remember this. If it is the level of the obstruction, whether it is intraluminal, something inside the lumen, or if it is the luminal, whether the lumen itself is narrowed or dilated, or extraluminal, something around the lumen which is abutting it. Okay, so that is how it is. Okay, and then goes for the duration, whether it is acute or chronic, and in the age group you get the pediatric and the adult. Okay, fine. So you can put it all, you can just imagine this one, and then you can list out all these things. Okay, if it is intraluminal, just think from the larynx to the trachea, what are all can be there. The vocal cord paralysis can be there, where laryngeal whelp can be there, laryngeal cleft will be there, and subglottic stenosis, congenital laryngeal atresia, and above upper airway from the nasopharynx, conal atresia, or some syndromic like a Pierre Robin syndrome, where you have a retronathia, the chin is very less developed, so they have a backward falling of the tongue. So you can fit any of these causes inside these ones. So you have to stratify it. Etiology is just like that. See, here they have given infectious causes, non-infectious causes, and non-infectious, which are symptoms at birth and which manifest after some while in the neonatal period, and which is in the after the neonatal period in the it might be in the pediatric age group or in the adult age group. So stridor can be from ranging from the congenital web to the carcinoma of the larynx, but you can stratify it. Like you can just think about the level of the obstruction, and then how long it has been, whether it is was an acute stridor. If it is acute, then it is mostly due to infection like acute epiglottitis, a croup, laryngotracheal bronchitis. Okay, so if it is acute, then it might be due to acute, can be due to a carcinoma of the larynx. If it is chronic, then it is a very long standing disease, so it's a laryngomalacia, it can be a tracheomalacia. So those are the things you have to deal, you have to think, so stratify it so that you can clearly understand the causes. So understand the causes and then you take it into your mind and then you mug it up. Before that, if you mug it up the whole list, there is no doubt you will be reproducing only two or three etiological causes from this list. I can bet you really. So if you understand this, you will be easily you can do it. So then comes, it's a disease or a condition, right? Then comes the clinical presentation. What are the clinical feature? Clinical feature, imagine that the patient is sitting in front of you, and then you are taking the history. Sign, what are the symptoms, when it started, what is the duration of the symptom, and how was the if it is a pediatric age group, then go with the perinatal history. How did the baby cry immediately, or the baby had any cyanosis, or there were any associated syndromes. So these are the clinical features. You can easily write it down. So if it is a stridor, okay, it was an acute onset stridor. The baby had the stridor from the birth. Usually, any stridor essay is given as a not as a topic but as a case study. Okay, they will be giving as a child, 2 months year old child with a stridor presented to the ENT department. It's the question will be more like this. Okay, so that's how it is. So then you go with the examination part. So how to examine it? What are the heart and the respiratory rates? The respiratory rate will be obviously more than 20, and if there is any cyanosis, will be there because the patient is having very less oxygen to the lungs. The use of accessory muscles of respiration because it has to inspire more, and nasal flaring will be there because the upper airway is has to take more amount of air inside. And what is the level of consciousness, responsiveness, the infection in the oral cavity, because you have to check for any infection in the oral cavity also because any acute epiglottitis might be there. Crepitations or masses in the soft tissue of the face, neck, or the chest can be there, but be a pneumothorax sometimes, or there can be some trauma which causes this crepitus, and the deviation of the trachea. Maybe they, when one of the lung is not ventilating properly, then the trachea may be deviated to the one side. So and then once you are done with the examination, then what you do is management part. What is the management? First one, simple management. Just check what is the neck status. X-ray of the neck gives you a clear picture whether it is an obstructive disease or a non-obstructive disease. Simple. Obstructive disease has some mass or something which is obstructing it, or a foreign body too. Or if there is no obstructive disease, then the airway will be patent, but still the stridor will be present. Okay, and then the X-ray chest to rule out any chest condition that is going to cause this, and then go ahead with the CT and MRI. See, in while writing the theory, never underestimated. You can give whatever the investigations, whatever the treatments you which can be done, because since it is not a condition. If it is a case study, then you have to precisely know for what you are doing the CT and what you are doing the flexible endoscopy or like that. But for a condition, if it is given as a condition, just as a condition, stridor, and how you are going to manage it, then you can clearly write down, jot it out, everything, whatever the investigations you know that we are going to know for stridor, you can jot it down and then you can list it out. Okay, so CT and MRI clearly gives you whatever what is the condition of the larynx and what is the condition of the chest. Flexible endoscopy, if it can be attempted, because it is Stridor. But if it can be attempted, if the patient is comfortable in attempting, then you can do a flexible endoscopy to see the status of the larynx, the vocal cords, and then the status of the subglottis also. So rigid endoscopy usually is done only with under general anesthesia, but yes, you can also do that, because in Stridor there is no point in doing a rigid endoscopy, because the patient is already in Stridor. You can't put him under general anesthesia. No anesthetist will dare to do that, because putting a intubating a patient in Stridor is really that difficult, and the anesthesia anesthetist will have his adrenaline pumped like anything. Okay, and then the other test like polysomnography or a pulmonary function test can also give you what we are going to deal with, whether it is an obstructive sleep apnea or what is the status of the lung from the pulmonary function test. One, then what is the treatment part now comes. Then treatment divided it into medical treatment and the surgical treatment. So medical treatment, it is an emergency situation. We give IV steroids to stabilize it. Adrenaline 1000 nebulization we give it to the child, and then antibiotics to prevent any secondary bacterial infection. And the first and the major thing is securing the airway. So securing the airway can be done with any of these four things. Either you can intubate the patient, either you can jet ventilate it, either you can do a cricothyroidotomy if it is dire emergency, and if you have time still, then you can do a tracheostomy. So securing the airway is of utmost important in Stridor. So if it is a foreign body, you remove the foreign body, then the whole thing is done. Okay, so that is how it is done. So in uh, surgical side, you do a tracheostomy for Stridor most of the time. Okay, so surgery is just a tracheostomy you do, and then where what are the indications in which conditions we do surgical tracheostomy is severe laryngomalacia, if there is a laryngeal stenosis, tracheal stenosis, not lower tracheal stenosis, only upper tracheal stenosis, laryngeal and tracheal tumors and the lesions like laryngeal papillomatosis, and foreign body aspiration, retropharyngeal abscess, peritonsillar abscess. Here we can go for surgery. Peritonsillar abscess we usually do a tonsillectomy, interval tonsillectomy after that. Very rare that peritonsillar abscess patients will go for Stridor. So this leaves us with two extra questions like tracheostomy and the retropharyngeal abscess. These were repeated more in common. Retropharyngeal abscess as a short note was repeated many times. Peritonsillar abscess also was repeated, and tracheostomy was asked as an essay in most of the topics. So tracheostomy now comes into the surgery. So surgery or a procedure. So just have the blueprint of it. So I just gave these subheadings because these were the subheadings which were asked in the exams, like what were the functions of tracheostomy, what is the operative procedure, what are the indications of tracheostomy, and what are the complications of tracheostomy, and what are the types of tracheostomy tubes. So these were the questions which have been asked. So that's why I had given. Otherwise, you can just think about it. And what tracheostomy means, it is a surgery. So if it is a surgery, then it should have a history. Who did it first? Antonio was the one who did it first. And then what are the functions? It reduces the dead anatomical space, anatomical dead space to more than 30 percentage. So it relieves the upper airway obstruction. It can be used for bronchial lavage, and it can be used for intermittent positive pressure ventilation. You can deliver humidification medications, anything through the trachea. And even if you are going to take the patient for surgery, you can deliver general anesthesia through that. And it reduces the airflow resistance, it protects aspiration of contents, and you can very well put a suction and then clean the tracheostomy tube, and it is very easy to handle it, and it prevents the intubation injuries. Like if you are intubating, keeping the patient for more than 7 days or a week, the larynx is going to get edematous, and once you are extubating the patient, he is going to develop a laryngeal edema or some injury in the larynx. He can even develop a laryngeal web or a granulation. So those things can be avoided with tracheostomy. So The functions of tracheostomy are these listed out things. So this has been repetitively asked in your exams. Okay, and then the indications of tracheostomy. What are the indications of tracheostomy? Only two categories. One is obstructive indication, another is a non-obstructive indication. And in obstructive, whether it is congenital or acquired. If it is non-obstructive, then respiratory insufficiency, bronchial lavage, and post-surgical. Okay, so respiratory insufficiency, if the patient is not able to is having dyspnea or is not able to respire properly, and then if the patient needs a bronchial lavage, also we bronchial toileting, that is what we do a tracheostomy. And post surgically, like after a laryngectomy we had removed the larynx, so there is a trachea, then it's a permanent tracheostomy. Or doing a surgery in the oral cavity, and later on there is some problem in the airway, so we do a tracheostomy post surgically, so that for another 5 days we keep the tracheostomy, and then after that we close it. Okay, so if it is congenital, whether it is intrinsic or extrinsic. If like intrinsic means if it is a laryngeal web, or extrinsic cystic hygroma, which is going to push the larynx, or which is going to cause a stridor from outside. Okay, so acquired inflammatory conditions like infections of the larynx, or any like acute epiglottitis, acute laryngitis, and trauma, laryngotracheal trauma. When someone met with an accident or any trauma, then the larynx has collapsed, then we do a tracheostomy for securing the airway. Neoplastic carcinoma of oropharynx, carcinoma of hypopharynx, carcinoma of the larynx, we do a tracheostomy. And some miscellaneous causes, like when the patient is in stroke and he has been intubated and for more than a week, and then now for prolonged ventilation, you do a tracheostomy. Okay, so contraindications, absolute contraindications, relative contraindications. For tracheostomy, there is no absolute contraindications. Relative contraindications, yes, they do are bleeding disorders, and uh, that's all. And the bleeding disorders and other things can be taken care, but those are relative contraindications only. Tracheostomy is a life-saving procedure, so we don't have any absolute contraindication. So, what are the types of tracheostomy which we know? So types of tracheostomy has been asked. So what are the types? So types can be divided according to the purpose. According to the purpose, it can be a temporary tracheostomy for a time being. We want to maintain his airway, secure his airway. Once his airway, airway is done, once his larynx and throat is normal, we remove the tracheostomy tube, decannulate him. That's it. Permanent tracheostomy, when the airway is irreversible, when you can't have a patent airway, then we have a permanent tracheostomy. The classical example is a carcinoma larynx, where we do a permanent tracheostomy. And timing, whether it is elective or emergency. Most of the time, tracheostomies are done as an emergency procedure. Elective do happen sometimes. And level of tracheostomy, where you do it, it can be divided into high, mid, and low. When you do it from the first and the second ring, it is usually we do it in the first and the second and the third ring. If it is first and the second ring, it is high. If it is less than for third and fourth ring, then we do it as low. Call it as low. So if it is based on the procedure, open tracheostomy, which is the conventional tracheostomy, where we cut, give the incision horizontal or vertical, dissect the strap muscles, reach the trachea, open the trachea, then place the tube. Okay, or percutaneous, which are mostly done by the anesthetist nowadays, where we just trace the trachea and then use a guide wire and then dilate it, and then you insert the tube. So before doing the tracheostomy, what are the pre-procedure workout you are going to do? Pre-procedure, you have to work up like the blood parameters, whether the bleeding and the clotting mechanisms are right, and then have to have an informed written consent, and then injection TT. Any surgery, injection tetanus toxin is very must, and injection lignocaine, you have to give a test dose. just to check for the anaphylactic reactions for the lignocaine, and then get a X-ray neck just to see whether the airway and the tracheal position is optimum, and then go for the procedure. Procedure can, when you go for the procedure, it's just position, because before the procedure we have to position the patient in the supine position with the head, with the neck extended, okay, and give a local infiltration over the area where you have going to the incision. It can be a horizontal, or it can be a horizontal, or it can be a vertical incision. Then dissect the strap muscle, you find the trachea in the midline, and then do a tracheotomy. Tracheotomy is nothing but opening of a opening over the trachea, and then open it, and then put the tube, and then you're going to close it. That's it. That's the procedure. Complications, what are the, any surgical complications is divided into immediate and late. Immediate complications, every time you can blindly write bleeding, injury to surrounding structures, and since it is a trachea, aspiration of blood can happen, okay, or aspiration of saline when we are falsely injecting into it, or it can go into a false track. False track is, it is the tube goes into somewhere else, not into the trachea, okay. Late complications, again you can give bleeding. Late bleeding is due to the infections, okay, and then it can have pneumothorax in the post-operative period. The tube expulsion can happen, so you have to suture the tube, and delayed wound healing can be a complication. Tube block and tracheostomy dependence. So these are the things you have to go for with the complications. Yes, Raghu?
Yes, sir. Continue, sir.
So this is the other question which has been a part of the essay. What are the types of tracheostomy tubes? Very well know the metal tubes and the non-metal tubes. The very commonly used are the Fuller's tubes and the Jackson's tube. And non-metal tubes are otherwise known as the Portex tubes, or they also have Portex, Traco, and the Shiley. Portex is very used for metal tubes are used for long-term usage, and non-metal tubes are usually used for short-term usage. But Traco and Shiley tube are used as a long-term tubes. But in metal tubes, the Fuller's and the Jackson's tube, they are made of German silver. It is not a stainless steel silver. It is made of German silver. Okay, so just to mention about the tubes, and if possible, just try to give some differentiation between the metal tubes and the non-metal tubes. If you had seen the metal tubes and the non-metal tubes, you can very well do that, because the metal tubes usually have one inner tube and an outer tube. The outer tube remains there, and you can pull out the inner tube and you can insert it. But whereas the Portex tube, it is a single tube. There is no inner and outer tube. But Traco tube usually has an inner tube and an outer tube. And in metal tubes, you have a speaking valve so that the patient can obliterate the tracheostoma and then he can speak. But in Portex tube, he won't be able to speak. Okay. Um, Okay, so this leads us with the third question of tonsillitis. Tonsillitis is another again a very repeated question over the couple of years, and so these are the topics with which they were asking: types, etiopathogenesis, diagnosis, complications, management, and the differential diagnosis of membranous tonsils. So we'll just look out in brief. So chronic follicular tonsillitis, parenchymatous tonsillitis, hypertrophic tonsillitis, lacunar tonsillitis. They can ask whatever it might be, all the four remains the same. Okay, so don't get confused with the terminologies. All the four remains the same. So all the four mentions the same disease. It's the chronic tonsillitis. So what are the types of the tonsillitis? Based on the duration, it can be classified into acute and chronic. Based on the pathology, it can be classified into follicular tonsillitis, catarrhal tonsillitis, membranous tonsillitis, and parenchymatous tonsillitis. Follicular tonsillitis when there are follicles over it, some over it. Catarrhal tonsillitis when tonsil is also infected as a whole with the oral cavity, as a part of oral cavity. And then membranous tonsillitis when there is a membrane over the tonsil. Then parenchymatous tonsillitis when the whole tonsil is involved, the parenchyma of the tonsil is involved. Anatomically, it can be an adenoiditis or a fascial tonsillitis or a lingual tonsillitis. So these are the types of tonsillitis you have. The etiopathogenesis is the organisms, various organisms, bacteria, viruses, whichever, and recurrent acute tonsillitis. And what are the complications? Usually, what are the complications of tonsillitis? It's very repeated topic. Complications of tonsillitis, you get it in your clinicals. You might find some examiners asking you in the clinicals also. Okay, so middle ear infections, otitis media, quinsy, peritonsillar abscess, where we do a interval tonsillectomy after 4 weeks of treating the quinsy, and obstructive sleep apnea, scarlet fever, rheumatic fever, and glomerulonephritis can be the complications of tonsillitis, recurrent tonsillitis, and differential membrane of the membranous tonsillitis, diphtheria, Vincent's angina and infectious mononucleosis, granulocytosis, leukemia candida, and malignancy. Out of this, you can be asked whether it is a false membrane or it is a true membrane. What is the disease with true membrane? What is the disease with the false membrane? The true membrane, if you peel it out, it will bleed. The false membrane, if you wipe it out, it won't bleed. False membrane example, candidiasis. True membrane example, diphtheria. So comes to the other question, the causes of dysphagia. So what are the causes of dysphagia? So imagine dysphagia. It is difficulty or pain in swallowing. Pain in swallowing is odynophagia, but we will take that too also. So it has to go from the oral cavity, oropharynx, and then into the esophagus. So oral cavity, it is not any problem in the oral cavity is not going to produce any dysphagia, but from the oropharynx and in the pharyngeal part and in the esophageal part, it is going to cause dysphagia. So we now divide where is the problem. So it can causes of dysphagia. Just imagine can be divided into the esophageal and the oropharyngeal. Simple. In esophageal, whatever it comes, achalasia, diffuse spasm, stricture in the esophagus, foreign body in the esophagus, esophageal ring, GERD, eosinophilic esophagitis, anything, mucositis due to radiation therapy can cause. So those are local. Okay, anything inside come only due to which is affecting the esophagus alone. Then comes the neurological part or the systemic part. Some neurological disorders can which affects the mind reflexes can cause dysphagia. So it can be oropharyngeal, it can be esophageal, and in esophageal or oropharyngeal, it can be local and it can be systemic. The same thing here. Oropharyngeal, whatever can be, when the tonsils get involved, tonsillitis, retropharyngeal abscess, when the posterior pharyngeal wall is bulged out, malignancy, when there is a malignancy sitting in the hypopharynx or in the oropharynx, Zenkus diverticulum. So, and any disease, systemic causes, neurological disorders like multiple sclerosis, muscular dystrophy, Parkinson's disease. These are the neurological disorders that cause dysphagia also. So it can be local or systemic. It can be esophageal or oropharyngeal, and in each of them, it can be local or systemic. Now comes leads to acute retropharyngeal abscess. So now imagine acute retropharyngeal abscess. This came from causes of dysphagia. Okay, they would ask what are the causes of dysphagia? Enumerate it and give a brief note on retropharyngeal abscess. That that was an essay actually, and that is how I split it out. So so how to go about it? Just think about dysphagia and think about the anatomy, think about the physiology. You can enumerate whatever you want. Okay, so that is how you give the causes. If you write it down, it takes 2 pages for this causes. You can even go and elaborate it, but not that too big. You won't be having much of a time to elaborate it. And then comes the retropharyngeal abscess. It's Part of the same question only. Retropharyngeal abscess. Imagine the blueprint which was discussed earlier. What was it? Retropharyngeal abscess is a pathology or a condition. It's a disease. So, etiology. What are the etiology? The most common etiology is tuberculosis, pot spine. Any infection from the vertebra passes into the retropharyngeal space that causes this retropharyngeal abscess. Other bacteria which causes enumerated staphylococcus, other those bacteria, those which can cause a retropharyngeal abscess can know. It can also go from the parapharyngeal abscess. So parapharyngeal abscess can be due to the dental abscess. So these are the etiological factors. Then comes the pathogenesis. What is the pathogenesis? It is a retropharyngeal space is filled with pus. That's the pathology. So just go for the clinical features, signs and symptoms. What are the signs and symptoms? You have a bulging in the posterior pharyngeal wall. You have the neck stiffness. You have dysphagia. The answer is there in the from the question itself. Okay, and what are the signs? Once you open up the mouth, you find a bulged out posterior pharyngeal wall. Okay, in the midline, and the patient comes with a stiff neck. Okay, and what is the management? Any abscess. If it is an abscess, you have to drain it out. So surgery is the management. Medically, what you are going to do to prevent further infection? Antibiotic, broad spectrum antibiotic, analgesics, antipyretics. Okay, same thing. Plummer Vinson syndrome. Plummer Vinson syndrome is the same. It's a disease or a condition. Just imagine it. What is the etiology? Malnourishment, low iron intake. It is more common in the female population who have iron deficiency anemia. And clinical features. What are the clinical features? Agranulocytosis, glossitis, anglostomatitis, chylonychia, and cricopharyngeal web. These are the things. Okay, what are the investigations you are going to do? This classically gives you dysphagia. Okay, so what is the investigation? Clear cut investigation. Barium swallow. Ask the patient to swallow the barium. Take an x-ray. See it wherever the obstruction is. You will classically find a cricopharyngeal web there. Okay, and you can even write a ct scan also, contrast and ct scan also, or an mri also, where you can see the cricopharyngeal web. Even you can write upper gastroendoscopy, upper GI endoscopy, gastrointestinal endoscopy also, where you can clearly see the cricopharyngeal web. And then comes the treatment part. It is web is there. Either you have to cut the web or you have to dilate it surgically. So surgery is dilatation of the cricopharyngeal web. Simple. And there is iron deficiency anemia, which is leading to this cricopharyngeal web. Hence, you have to correct the iron deficiency anemia. So, what are the treatment you are giving for iron deficiency anemia? You can give either as a iron as a parenteral if it is if the hemoglobin is very less. You can even transfuse blood if it is okay. If the hemoglobin is slightly low, then you can maintain it in the oral doses of ferrous sulfate and iron and ferrous sulfate tablets. More than enough. Okay, done. So I think with that blueprint, if you go, you can start answering any type of question for that matters. So hoarseness of voice is another question. So hoarseness of voice also the same blueprint. It is just a condition. Okay, why I had shown this investigation and management is hoarseness of voice investigation and management was asked in an essay. So that's why I had put it like this. So hoarseness of voice. What are the causes of hoarseness of voice? So voice is produced by the vocal cord from the larynx. So anything which is disturbing the voice production is going to produce hoarseness of voice. It can be inside the larynx. It can be outside the larynx. Outside the larynx, it is going to press it. Inside the larynx, it is going to go into the it is going to disturb the vocal cord in producing the sound. So what are the causes? Local causes, systemic causes. Okay, so what are the local causes? It can be from starting from the birth, congenital verb, and then laryngeal infections, acute epiglottitis. It can be cord palsy. Cord palsy can be due to anything, but cord palsy produces hoarseness of voice and can be a trauma. Some trauma can be there. And if there is any mass lesion inside the larynx, it can produce like a carcinoma, like a papillomatosis. Okay, at foreign body in children most commonly can produce hoarseness of voice. So, isn't it very easy? Just imagine it, and then you can go ahead in answering it. Systemic hypothyroid myxedema. There is edematous vocal cord, hence you get the hoarseness of voice. Laryngomalacia, you have stridors of hoarseness of voice, and neurological disorders like Parkinsonism and other things. Systemic sclerosis. Simple. So hoarseness of voice, it's simple. Then you go with investigation. Investigation, what you want to see? The larynx. How you are going to see? Video laryngoscopy, flexible endoscopy, or a direct laryngoscopy. Simple. And non-invasive investigations, what are they? CT scan, MRI, clear. Stroboscopy also you can use to assess the voice assessment. Simple. So investigation part is done. Enumerated. Management. Management, how you are going to treat? Medical and surgical. Medical part, acute infections and laryngeal infections, hypothyroidism, those are treated medically. The others like surgically, how you are going to treat a hoarseness of voice? Phonosurgery. The surgery which is done in over the vocal cords is known as phonosurgery. So if there is a vocal cord palsy, we do medialization, or if there is adductor palsy, then we do lateralization, or we do reconstruct or if there is any tracheal stenosis, or if there is any laryngeal stenosis, we just cut the laryngeal web with the laser. If there is a papillomatosis, we remove the papilloma with the laser. If there is a carcinoma, we remove the carcinoma with a cold steel or a laser. That's it, surgically done. So it's very easy that we got a whole essay in one single slide. So carcinoma larynx was also asked. It's a disease or a condition. Imagine introduction of carcinoma of larynx. Etiology. Etiology: smoking, alcohol, human papillomavirus. What is the pathology? Most common is a squamous cell carcinoma. Sometimes adenocarcinoma can also happen. Sometimes chondrosarcoma can also happen. There are other various carcinomas also, but most common is squamous cell carcinoma. Clinical features: anything that's affecting the larynx will produce hoarseness of voice, cough due to aspiration, and then dysphagia when it is involving the esophagus behind that you have difficulty in swallowing. Then, what is the diagnosis? How you are going to diagnose this? It's a carcinoma. Your diagnosis is only two. One, you have to prove the disease whether it is carcinoma. Take a biopsy, prove it. Done. You another, you have to stage it. You have to know the extension wherever it has spread. So, do an imaging, CT scan or an MRI. Done. And then, what is the treatment? Any carcinoma, you have only three ways of treatment: surgery, radiotherapy, chemotherapy. Surgery, you do a partial laryngectomy or a total laryngectomy, and then radiotherapy, you give an IMRT or 3D conformal radiotherapy. Chemotherapy has very less role. That's it. So after treatment, there is another one thing in carcinoma larynx is rehabilitation. Rehabilitation is nothing but rehabilitating the patient for voice production. It can be an electronic larynx, or it can be an esophageal voice, or it can be a prosthesis, tracheoesophageal prosthesis. Done. Carcinoma larynx. You can write it for 3 pages, no, four pages. So vocal cord palsy. Now this question is very likely to be asked, or very less likely to be asked. But even then, this is a very important topic. So vocal cord palsy. The moment you imagine vocal cord palsy, you imagine the vocal cord and the positions of the vocal cord. Okay. So median, paramedian, cadaveric, slight abduction, and the complete abduction. Okay. So now you imagine what are the etiology of the vocal cord palsy. There is something inside the vocal cord which is going to disturb to produce it. And another thing is the extrinsic factor, that is the nerve supply is cut off. Okay, so there are only two etiological causes. What are the etiological causes which is going to cause this vocal cord palsy? Sitting over it is carcinoma. Any carcinoma of the vocal larynx, a carcinoma of the hypopharynx here also will produce vocal cord palsy. And mm, the other one is the nerve supply. Either it can be a vagal nerve paralysis or it can be a recurrent laryngeal nerve paralysis. So if it is a vagal paralysis, it will be in intermediate position, cadaveric position. If it is in recurrent laryngeal nerve paralysis, it is in paramedian position. So that's the etiology. So vocal cord palsy, we know the etiology now. You enumerated whatever the vocal cord palsy for whatever the causes of hoarseness of voice can be enumerated, can also be enumerated here. So there is nothing wrong with it. And then what is the nerve supply? Obviously, the nerve supply has to be dealt with. The larynx, it's so simple. Everything is supplied by the superior laryngeal nerve except for the cricothyroid by the recurrent laryngeal nerve. And then comes the treatment. How you are going to treat, as already dealt with. Vocal cord palsy, if it is abductor palsy, it is adducted, so we lateralize it. So if it is lateralized, if it is a cadaveric position, you medialize it to get a good voice. Okay, so if it is a bilateral abductor palsy, that is both the cords are adducted, then you have to do a tracheostomy. So only three things: medialization surgery, lateralization surgery, and tracheostomy is the surgery treatment for vocal cord palsy. Done. So the other question is anatomy of larynx. If you are very unlucky, you will be asked this question also. Anatomy, simple. What are the subsets of the larynx? Supraglottis, glottis, subglottis. What are the membranes of the larynx? Quadrangular membrane, conus elasticus. Briefly mention about it. Cartilages. What are the cartilages? Three paired cartilages, three unpaired cartilages. What are the muscles? Intrinsic muscles and the extrinsic muscles. And what is the nerve supply? What is the blood supply? Simple. So just go through these anatomy of the larynx. It's very easy. For muscles, don't get confused with the muscles. Extrinsic muscles are the muscles which is going to make the framework of the larynx, and the intrinsic muscles are the muscles which form the larynx as a whole. So intrinsic muscles can be divided into adductor, abductor, tensor, relaxor. Only four. So only abductor is a posterior cricoarytenoid. Rest other things are the adductor, tensor of the vocal cord, cricothyroid, and relaxation of the vocal cord. That's it. Just four muscles. Done. And cartilages, paired cartilages, unpaired cartilages, 333. Unpaired cartilages, thyroid, cricothyroid, epiglottitis, paired cartilages, arytenoid cuneiform, corniculate. So just enumerated, you will get everything. And what is the nerve supply of the larynx? And what is the blood supply of the larynx? Simple. So if you're still more unlucky, you get this one, infections of the larynx. Infection, any infection divided into acute, chronic. Acute laryngitis, acute laryngotracheal bronchitis, which is known as croup, acute epiglottitis, pertussis, diphtheria, infectious mononucleosis, mycotic laryngitis, and laryngopyosis. These are the various infections. It's very easy to understand. Most of the time, the clinical features remains the same. It is only the presentation which is going to differ. So it is very easy for you to enumerate it. And chronic non-specific laryngitis is the other one, which is LPR is nothing but the laryngopharyngeal reflux. That is nothing but the counterpart of GERD, gastroesophageal reflux disease. Okay. So another one essay was something related to the parotid glands, and they are very commonly asking about this parotid gland anatomy. That's more from the anatomical point of view, only anatomy of larynx and this anatomy of the parotid gland they were asking. So parotid gland, you can easily know the relation. Okay, anterior, posterior, anterior masseter, posterior sternocleidomastoid, superiorly by the zygomatic arch, inferiorly by the mandible. And what is the morphology? It has a superficial lobe and a deep lobe separated by the branches of the facial nerve. And It is microscopically it is divided into acne, which leads into the duct, and each duct leads into the major duct, which is known as the Stenson's duct, which opens into the vestibule of the upper second molar, and then comes the blood supply, then comes the nerve supply, auriculotemporal nerve, the sensory one, and then the autonomic one, the aortic ganglion, and the tympanic plexus, the blood supply by the superficial temporal and the posterior auricular, occipital, and then comes the applied anatomy. Water, it can be lead to infections of the parotiditis, acute parotiditis, or any malignancy can also occur in parotid gland, or there can be a calculus inside the parotid Stenson's duct which lead to parotiditis. So it can be a calculi. That's it. So you just think about the blueprint and then go with answering any of the answers. So pre-malignant lesions of the oral cavity. So we have a pre-malignant, it's very very unlikely question, but still worth reading it. So give the definition of a pre-malignant lesion. Nothing but a condition which leads into development of a malignancy as compared to the normal tissue. So this develops into malignancy. This has a probable more amount of probability of developing into a malignancy. And then comes the etiology. Etiology, the same as for cancers: habits, chewing tobacco and smoking, alcohol, and human papilloma virus too. And then the presentation, usually what it looks like a leucop. There is two, one is a precancerous lesion and another is a precancerous condition. So lesion and the condition are different. So leukoplakia, whitish patch; erythroplakia, reddish patch; and the palatal lesions in the reverse smokers. Smokers who reverse smoke, they do have the palatal lesions there. And precancerous conditions like submucous fibrosis, which is very very predominant in our Indian subcontinent, is also there, and actinic keratosis, keratin pigments over the buccal mucosa, lichen planus, discoid lupus erythematosus. These are the conditions which can lead into a malignancy. Okay, so presentations is nothing but how they look like. So how you are going to treat it? Simple: taking a biopsy, study it, you know whether it is a pre-malignant or a malignant lesion, and then how to manage it. Stop the habits. Habits is the one which is going to cause it. Stop the habits, and then we give retinoids and anti uh, vitamins and vitamins, zinc and retinoids. Okay. So if you are very very unlucky, you will get this question also, esophagus, but it is very rare. Hardly one time in some 10 to 12 years of paper I saw this one. So just think about the anatomy. It's very easy, from the cricopharyngeus to the cardiac sphincter, and what is the centimeter from what is the level, from which level to which level in the corresponding to the vertebra, and what are the etiology of esophageal diseases. Like most commonly they ask about the structure of the esophagus and the achalasia cardia. Structure of the esophagus and achalasia cardia, more or less the same management structure. You have to dilate it with the serial dilators. And management of achalasia cardia, only one, Hellas myotomy. If you write that one, that's it. Clinical features: esophagus. So obviously you will have dysphagia, burning sensation in the epigastrium. So those, just think about it and you will get your answers right. So imagine, uh, get that blueprint whatever I told in the earlier slides, so that you can answer whatever the questions you can. If you have any queries, you can post me in the comment box. Okay, since there are I don't find any students listening now, so we'll have the, you can post me in the comment box so that I can answer your queries. Okay, and thank you for your patient listening, and uh, all the best for your exams, and hope I will see you back with the ear and the nose also too, or I don't know. The time and the schedule will be let you known by the organizers. Thank you so much for your patient listening.
Thank you, sir. Thank you so much. It was a great session, and almost all the questions from all larynx as well as the pharynx has been covered, including the oral cavities. So thank you so much, sir. Keeping this as a base, it will be easy for us to revise the larynx part as well as the oral cavity and tonsil part in ENT. Thank you so much, sir, for accepting our invite in this period of pandemic in spite of your schedule. You have just given us some part of your time in helping us in revising for the university exam. Thank you so much, sir. It was a great pleasure, great gesture for taking session for students through this open platform like our channel without any expectation from us. Thank you so much, sir.
Thank you, Ravi.
Thank you, sir.